In this lecture we're going to be covering mammography, and we're going to be talking about screening mammography and also about diagnostic mammography. The whole point of mammography is to pick up breast cancers early. The earlier we pick up the cancers, the better the prognosis for our patients. And as you can see from the first point on this slide, that if the tumours are picked up while they're only 1 to 9 millimetres, in about 90% of them we won't have any spread into the nodes around the axilla and the neck. And that is a positive because that means the chance of spread is far less reduced and ending up with metastases in remote parts later on down the track. So mammography is to pick up this breast cancers when they're at the calcification level, when they're still small, when we cannot actually feel them or know that there's anything going on there. And that's why even today mammography is still considered the gold standard for breast screening, because it's trying to find these small calcifications. And while other modalities are starting to see these small calcifications, at this stage they're not at development enough to replace mammography. So mammography will remain from now on into the future the gold standard for breast screening, which is screening to check for these breast cancers when they're at this small calcification level. Now generally they consider if you can get through 5 years post diagnosis, then they considered you cured. So if we're looking at in situ cancers which are still within the duct that haven't invaded out into the surrounding breast tissues, we're looking at an extremely high 98% survival rate in that 5 to up to 5 years. If, however, they have progressed further and they're more invasive, invading into the breast tissue and potentially the breast wall, muscles and things, then the survival rate, as you can see, is really quite poor and down around 20% for the 5 years. So that just shows again that it's this early detection that's important. We really want to pick them up while the cancers are small, causing us no symptoms, and they haven't spread. Now I'm not going to read through all of these, you can have a look, but this is a very interesting examples of some of the symptoms that the breast can show if we're suspicious of breast cancer. And what's interesting is the very last one, is the invisible lump. Okay, so sometimes, yes, there's things we can see that make us suspicious and make us go to have the breast checked, but in a great proportion of people there's nothing. They can't feel anything, they can't see anything, but there's something going on, and it's at that early stage, as I said, that we want to pick these cancers up, and that's the whole point of mammography. Now you will hear about screening mammography and diagnostic mammography, and a lot of this is just in relation to the type of a patient and his family and history. For early detection, there is a program which is the screening program, which is using women in the generally 40 plus but a little bit older age group to come every 2 years for a free mammogram. The idea being they've got no symptoms, no family history, no anything. They're just at the age where they're in the high risk for developing breast cancer. And if they have their free mammogram every 2 years, then we can watch and monitor. And again, remember, we're trying to pick these calcifications up and these breast tumours up when they're at calcification level rather than lump level. Once they've had the screening mammogram, they're sent off for reading. However, if then something is seen, they'll then be called into a centre to have further views performed. So it's just for all women in the general population in that high risk age group to come in and have screening. Now, anyone at any age can have a diagnostic mammogram and be referred by their GP. Diagnostic mammograms, it's just like any service in which there is a Medicare rebate. However, they're often out of pocket costs for the person having the mammogram done. So anyone can go from young to old. Generally, they'll have a symptom of some sort. So whether they've got a lump or a bump, or there's a family history of breast cancer, if they've had problems with their breasts in the past themselves, they were not suitable for the screening program. They need to be sent by their GP for a diagnostic mammogram. And if they need any extra views or anything like that, that's done at the time of their appointment. So really with the diagnostic, they're exactly the same as a screening mammogram, except the patient presentations are just completely different. Anyone with breast problems, family histories are encouraged to go to their GP and have diagnostic mammograms done and be referred, where the general population in this high-end age group can go for a screening mammogram. So just to be aware, they're exactly the same, it's just the patients presenting for the tests. Now, who does the screening mammograms? Well, you've probably heard of Breast Screen Australia, and they're the people, they have set sites where they will do the breast screening, and you've probably also seen breast screen buses around, so they can get out there to remote and rural areas as well to do this screening mammography. Now, lots of studies have been done, and they have shown that this screening mammography of females in that high risk age group for developing breast cancer has reduced the mortality rate by 30%. And that high risk group that we're talking about is in the age of 50 to 69 years. So every 2 years they're sent a letter to say it's time for your next mammogram. They go along to the screening and they do 2 views on each breast, and they're sent home, and then the images are sent off to radiologists for reading. Mammography images are usually double read, so the first radiologist reads, and then a second radiologist looks over them as well. It is a government funded program, and that's why the mammograms are free. Now, just a quick overview of the anatomy of the breast. The breasts themselves are really modified sweat glands, but instead of producing sweat, they produce milk, obviously, to feed the baby. They do sit over the anterior chest wall muscles, so anything growing within the breast can also invade into those chest wall muscles, and that's particularly relevant if we're talking about the male, because their breast tissue isn't as developed, so it doesn't have as much tissue to grow into, so it tends to invade into the muscle much quicker. Now, the breast is really made up of 2 types of tissue. It's sort of functional glandular tissue, which is the tissue that produces the milk, and then fat. And as with age, the breasts start off quite dense and quite glandular, got that functional tissue, and then as we age, that functional glandular tissue disappears and the breasts become nearly 100% fat. So it is the amount of fatty tissue within the breast that determines the size of the breast, the sizes of the breasts, and as we know, breasts are all different sizes, but we all have the same amount of functional glandular tissue. And the bottom point just shows the pathway of the milk from out in the alveoli up to the nipple. Now we can sort of break the breast up into 3 layers. So you have your superficial layer, which is your skin layer and fat. Then your mammary layer, which has got that functional glandular tissue in it and all the ducts and some tissues to hold it all together. And then the retromammary layer is sort of at the back, and it usually has the fat and muscles in it as we get deeper. To support the breasts and hold them in position and give them structure are things called Cooper's ligaments. And as I said, the males and females both have breasts and both can get breast cancer. It's just with females that with mostly their hormone estrogen, which spikes at puberty, the breast tissues develop in females where the males don't have the estrogen, so they don't get the breast development happening. So that's the difference, but they still have the breast tissue there and they can still get breast cancer even though the breasts haven't developed like they do in females. So just a quick diagram showing you the alveoli and the lobules. All our alveoli and lobules and all the ducts coming up to the nipple to feed the baby. So this is the functional glandular tissue, the hormonal tissue that reacts to the hormones. The yellow is just depicting the fat tissue, and then the white spaces in between are the Cooper's ligaments, which give the breast the structure. As you can see at the very back is the chest wall muscles, and then we're hitting rib cage, and if we were looking deeper you'd actually be seeing a lung moving back here. So it's sitting right on that anterior chest wall. So you can appreciate that if we have a tumour that's deep in the breast, that it can invade backwards into the chest wall muscle, where if it's sort of more in the middle or further towards the nipple, it'll grow in that area before it invades the chest wall. So obviously more nasty if they start invading the chest wall. So this is just explaining a little bit how the breast does change with age, which we've already talked about. But when we're young, the breasts are very dense, very glandular, not a lot of fat in them. As we age, we don't need that functional glandular tissue anymore. It starts to disappear and they become more fatty until postmenopausal. You're basically looking at a breast that is completely fat, so we've lost all that functional tissue. Now this is important to understand because obviously depending on your patient's age, your mammogram is going to look different, and we do compare. We usually compare the last or the 2 years. So if we had it 2 years ago, we did compare the one 4 years ago, and we're looking for change, and we expect them to be becoming fattier as the patient's obviously aged. If, however, for some reason they've gotten denser and more glandular, or we've got increases in densities in areas, then we need to be querying why. Now don't forget that some females go on hormone replacement therapy, which increases, is a tablet usually or an injection or a hormone implant, which increases their estrogen levels and keeps their body looking younger, and that can change the breasts as well and keep that glandular tissue there. So that is a question to always ask your patients and see if they are on hormone replacement therapy. Now if we have a look, these are a series of mammograms. So the younger mammographic image of the breast is on your right, and then you can see it's very white and dense tissue, not a lot of fatty tissue. As we progress to the left of the screen, that denser tissue is reducing, and we can see we've got the darker, more radiolucent fatty tissue coming in, and more fatty tissue to nearly 100% fatty tissue in the older patient. And that's generally speaking what we should be seeing in our patients as they age with their mammograms. Now when we look at the breast, breast, there's two ways that we refer to the breast. So firstly, we can break it into quadrants. If I draw through the nipple across, right through the nipple, then I've got 4 quadrants: upper outer, lower outer, lower inner quadrant, and upper inner quadrant. And we will refer to the quadrants. And if we're looking for lesions, we usually try and work out which quadrant of the breast it is in. Now then, the other thing we'll talk about is we look at the breast as the face of a clock with the nipple in the centre. So 12 o'clock up towards the shoulder, 3 o'clock out towards the armpit, 6 o'clock down towards the feet, and 9 o'clock in medially towards the other breast here. So if you think of the face of the clock going around, so we can say that we have a lesion at 1 o'clock or a lesion at 7 o'clock, and then we can say how far that lesion is from the nipple as well. So that's a little bit more specific than just using the quadrant method. So you'll hear both of those used, so the clock method or the quadrant method. And what we've given here is the rough breakdown of where the cancers tend to be. And what you find is the majority is in the upper outer quadrant. That is where you'll find the most glandular tissue in the breast. And it's often where people, the breasts are the most tender and the lumpiest will often be in this upper outer quadrant area. That's perfectly normal. So the area closest to the armpit, just here. Now, for mammograms, there is a tiny little bit of patient preparation, and this is because, and it is decreasing now, but a lot of perfumes, talcum powders and deodorants actually have metal in them. They have aluminium in them. So you can imagine that if we're putting those on our skin, we're going to have that it'll be very fine metal showing up on our mammograms. And we won't be able to tell the difference at times whether it's on the skin or whether it's inside the breast. And it can also mimic these small little calcifications that we're looking for breast cancer. So generally, patients are told not to wear perfumes, deodorants, talcum powders prior to their examination in that morning. So to have that day, have their shower and not apply any of these things, so that we're eliminating if there's any aluminium in the products that they have. You can buy products now without them, but obviously we don't know which patients have the products with aluminium or not. A big thing about mammography is previous films, and the patients must bring their previous films with them. As I said earlier, we like to compare the previous to today's, or if they've had more, then not the last ones they had done, but the ones they had done before that. So we skip a cycle in between with their films. So anyone who has a mammogram, please make sure you put your mammography films in a safe place. They're very important, and that you take them along to your next appointment, and anyone who knows anyone that has a mammogram, to let them know that those films they need to take with them and keep them in a safe place. So when they come, we do get them changed into a gown with the opening at the front. This is just to cover them over. Generally, once we get them into the room, we're going to take that gown off. It's just easier if it's off and out of the way, rather than just one side off and then the other. It's just once you're in the room, but keep them covered until we're in that room and it's a one-on-one situation. We put them in a gown with the opening to the front. Now, all centres will then have a form that the patients will fill out, or the radiographer will cover with the patients. And this is just an example of one of those. And it's quite thorough in that we need to ask them a lot of questions about family history and their own history with the breasts as well, and whether they've had any previous problems, surgeries, and all those sort of things. So if we look at here at the clinical history. Hysterectomy means that they've had uterus plus or minus ovaries. Sometimes they leave the ovaries, or they'll leave one ovary behind, so we need that information because obviously that's going to affect their hormones. Have you ever taken, this is the BCP, the contraceptive pill, or any hormone? So that's the hormone replacement therapy that we're talking about, which again will affect what we're seeing on the breast. And then if they've had any previous mammograms done, and when, and hopefully they have brought their films with them. Now when we come to the family histories, we ask about any cancers, including breast cancers. As you probably heard in the media with Angelina Jolie and her cancer gene, there is a gene that can be passed down in families, and it can affect the breast and also the ovaries. So we do need an idea of family history of any cancers, but particularly breast cancer. And they talk about breast cancers in the maternal side, they tend to be more interested in than the paternal side. And if they're sort of immediate first degree relatives, so if you're going, you know, it was my second cousin on my dad's side, they're not as concerned about that as if it was a mother or a sister or someone like that. So then any of the symptoms that we saw on those lemons in the second slide, so whether they can feel any lumps, they've got any discharge from the nipple. Not all nipple discharges are bad signs, but some can be. Pain, the breast can be painful generally, but if there's pain or new pain or different pain, or anything that's worrying the person about their breast, then we need to document that. And then, as I said, if they've had any procedures on their breasts before, so have they had lumps removed, have they had cysts drained? Mastectomy means that they've had a breast removed, so the breast has been completely removed. Breast prosthesis or implants, that's often referred to as augmentation. So breast augmentation means they've had breast implants implanted. And sometimes you can have lumps and partial area of the breast removed, and then have reconstruction surgery on the breast. And you can have that reconstruction surgery, full reconstruction surgery post mastectomy as well. So all that information is really important. Now if we look at the mammography machine, it's gone through a little bit of the modern technology process that our X-ray machines have gone through. So we used to have film, then we went to the computed radiography, which is now basically phasing out within Australia, and we now have digital mammography, and the new kid on the block is the tomosynthesis, which we'll talk about soon. Now this is the machine. It's fairly small, it's not big like our X-ray machines. The Xray Tube is in this top bit up here. This is where the Xray Tube sits. Underneath is our beam collimator, which just narrows down the beam like a normal X-ray tube. With a mammography, it's very important that we compress the breast as much as we can. The more we can flatten and compress the breast, the better the detail of the image we're going to receive. So we do have a compression paddle that comes down onto the breast and squashes it. This plate here is where the breast will be sitting, and the at the side here we can select the chamber depending on the size of the breast, so whether we're at the chamber close to the chest wall, in the middle, or further out, we can select that when we're actually on the side here. If it was a CR system or DR system with an imaging plate, it would actually put the imaging plate just in that black hole just there. Slide and click it in. Now this moves up and down in height, and it also rotates as well through 90 degrees on either side, so we can go right through from, technically we're going to call it a craniochordal view, but if you think of it as an up and down view and then a side to side lateral view, we can actually do. Now the mammographer will go in, this is the lead screen, so the mammographer goes in behind here, behind the lead screen, and actually pushes the button. So you're not, just like in an X-ray room, you're not standing in the room while you're taking the X-ray, so you're not being exposed to the radiation. The X-ray tube itself is a little bit different to our X-ray tube that we're used to using to take our normal X-rays. With mammography, we're going to use a much lower kVp because we're not needing to penetrate through any bone, we're only needed to penetrate through soft tissue. So generally your kVp that you're going to be using is around the 25 to 26 kVp. Therefore, the X-ray tube is a little bit different. So the anode is actually usually made of molybdenum as opposed to our tungsten that we're very used to. And that's because we don't need to produce these high kVps with these machines, and we're not producing as much heat because we're using the lower kVp range. So that's why we've got a different target material. And we're very used to in our window in our general X-ray machine being made of aluminium. In the mammography machine, it's actually made of beryllium. You can see our focused film distance, which we're again mostly used to being 100 centimetres, is a little bit shorter. And the big thing about our compression is that it's very, very important, and we need to apply as much compression as the machine can give to a particular breast and that the patient can handle, because it can be quite painful compression. But we are really going to get a far better image and much better detail the more we compress the breast. So it is really, really important. And if someone's breasts are particularly painful at certain times of their menstrual cycle, it's much better to do the mammogram when they're not as sore. So it may sometimes mean rebooking people so that we are able to apply this compression and get detail images. So there's two main views that we do on all patients who come from a mammogram. And the first of those is the craniochordal view, often abbreviated to CC. In this one, it's important to get the tube height up so that you can rest the breast on the imaging plate. So we lift this whole machine goes up and down together so that the breast sits on the imaging plate, and you want to pull the breast forward. You want the pec muscle on if you can possibly get it on at the back here. So pulling the breast forward onto the plate. It's also very important that we don't have any folds or creases in the breast or the skin. So as we can bring the compression down and apply the compression to the breast, you smooth out the skin with your hand and then try and get your hand out and not have it compressed as well. There's usually a foot pedal that you do the compression with, and there's usually a side roll button that then you can do finer movements with. So we're looking down from above. This is the compression paddle, pushing down on the breast, making the breast nice and even and thickness wise squashing it out. And these are the 3 density chambers, and generally speaking you'll choose whichever one, usually the middle one, whichever one's going to be over the bulk of the breast and over the glandular tissue of the breast. So that's our craniochordal view. It is a bit awkward for the patient. You need the shoulder back out of the way so they can't collapse their shoulder down over the breast, and you'll notice that there's this clear plastic guard, and that's to keep the patient's head out of the way so they can rest their head on the guard, but they tend, if it's not there, to bring their head forward and be in the way, so that this plastic guard keeps their head out of the way. Obviously very important to clean this guard in between patients, as well as the paddle and the plate just here. Covering the breast, you want it sitting out on its own, out in profile here. Once we've done that view, we then do a mediolateral oblique, which we often refer to as an MLO view. And in most places we are going to angle the tube to 45 degrees. So we do the angle of the machine and then we position our patient into the machine. These are rather uncomfortable because the square corner of the plate goes up into the lady's armpit. So again, you need to adjust the height so that they can rest their armpit over there. They then need to relax their arm. If they have their arm tense, they're going to tighten their pec muscle and it'll be hard to get it on. If their arm's nice and relaxed, the pec muscle will be able to come on nicely. With these, again, you have to pull the breast out and often lift it up a little bit so it doesn't sink off the bottom, particularly if it is a larger breast. And again, you want the nipple out in profile, so you can't have it flip under or on top. And you don't want any skin creases. If you've got any skin creases, you have to add your compression on again. And as you can see on this image here, we get right back to the chest wall. So we basically scrape when we put our compression down across the sternum and apply the compression as best we possibly can. Again, the rest of the head and the body out of the way when we do this image. But big thing is the relaxing of the arm of the patient. That's very important so that you can have your pec muscle on in through here. Again, as much compression as you can possibly apply. And this is the medial-lateral oblique view and what we're looking at. Now, this is the pectoralis muscle in here, and it should come down, they say, at least halfway or roughly to in level with your nipple, and therefore you've got enough muscle on. If you only get a little bit of muscle on, often they'll want you to repeat the image. So it needs quite a bit of that pectoralis muscle on. Sometimes you'll also find large round ovally masses up in here, and they'll be lymph nodes. There's none on this image, but it's perfectly normal to see them. So we can have the lymph nodes up in the axilla. We can also have lymph nodes within the breast tissue as well. So this is just pointing to a little lymph node. Obviously, they're often mainly seen up near the armpit. This is pointing to a blood vessel coming down. Again, we've got our glandular tissue and our fatty tissue, and nipple sitting out here in profile, not tucked under, we can see it nicely. And this is just basically the bottom of the breast. If you've got that inframammary angle on, you've got the bottom of the breast on, which is important. Now, there's lots of other views that can be then performed. We can do lateral views, we can do magnification views, and we can do cone compression views. And we're going to talk not about the lateral view, but the magnification and the cone compression views. But those two views, the craniochordal and the medial-lateral oblique, are your two routine views. They're what I've done for all women coming to the breast screening and all women coming for a diagnostic mammogram as well. And then from there we decide what is or isn't needed. Now, tomosynthesis is the latest technology that is now becoming very, very common within mammography departments. So anyone buying new machines are buying them with this tomosynthesis ability. And this is really using tomography, which some of you may be aware of. We've used in the past looking at kidneys. And the Xray tube actually moves. So it moves through an arc. It'll swing, as this diagram shows, from one end through perpendicular and to the other end. So it moves through usually about a 60 degrees, so 30 degrees on either side of straight. And as it moves, the patient stays nice and still. Then multiple X-ray images are required when it swings. So it's called tomosynthesis of the breast. It does increase the patient's overall dose. However, they have created it in that it delivers a fraction of the radiation dose as it moves around. So yes, overall it's a slightly increased radiation dose to the breast, but it's not as huge as you might expect because they have sort of fractionated the dose. The great thing about this is that we're getting multiple images, so we're getting much better detail, and where little things can hide in the dense glandular tissue, with the multiple images hopefully we can see what's going on. So it's very new technology and very interesting. Now this is quite a good video. I'm not going to click on it, I'll leave it for you to have a look at this video. It's a radiologist talking through some images and showing you the difference, which is really worth and seeing the tube move and that, so it's really worth a look. And then if anyone would like any further information, there's an article there. It's quite a long article, but it's got lots of images in it and it explains the technology further. So I do recommend looking at both of those. Now, the idea of spot compression is if we've got an area that we want more detail of, if we compress it, we're going to see it better. So we're not worrying about compressing the rest of the breast, it can stay. We just compress as much as we possibly can the area of interest. So the paddle that we use, there's lots of different paddles and paddle shapes and sizes, but this is a spot compression paddle. So you can see now it's not as big, it's rather small. So it's only going to compress that part of the breast that it comes in contact with. Obviously the difficulty with spot compression views is making sure that you're putting this paddle over the area of interest. So you have to work out where the lesion is in the breast and what part of the breast you are going to compress. So the whole idea is compress the tissue out more, it'll give you much finer, better detail of the lesions, and that will hopefully help you make a decision whether what you're looking at is benign or malignant. And spot compression is usually used with magnification rather than just compression on its own. It's all about producing a better image so we can make a decision. So if we look at these two views here, so this is a mediolateral oblique view, and here's our mass that looks different to the rest of the tissue. And so just on that, it's a bit blurry, it's hazy, we want to see the borders of it nicely. So what they've done here is magnification and the spot compression. So you can see they've only compressed up that area of the breast, they haven't compressed the rest, pushed it out, flattened it out, and you can see it's actually quite complex area, and now we can see the borders of the tissue much more clearly and get an idea of whether it's invading into the surrounding tissues and whether it's nasty or not. So this is a spot compression with magnification, and as I said, most of the time we do the magnification as well, just to make it bigger and make it easier to see. So how do we do the magnification? Well, we're just using the air gap technique. Breast goes on here, there's our little spot compression plate, and then we've got nothing, and our imaging plate or detector will be down here. So we're just using the good old air gap technique to magnify up that area. But again, you can see it's very important that you work out what part of the breast is going to be put in this area, and sometimes you have to do multiples if you miss it. Now if you miss lesion, then you have to do it again. So on this one, the arrow's pointing to an area here which has some calcifications in it. Again, really hard to see. This has some lymph nodes. There's a lymph node and some lymph nodes up in there. So often you'll see mammographers and radiologists, they'll be looking at the mammography images with magnifying glasses to have a look as well. And then this is a cone magnified view, and now we can see those calcifications and the pattern of them much clearer. And from that, the radiologist can then make a diagnosis as to what they might be or what further modalities, imaging or biopsies, etc. might be needed for the patient. So let's now look at some of these pathologies and what could mean benign, what could mean malignant, and with most things, if in doubt, further imaging plus or minus biopsies is the way they usually go. So you can have lesions that are nice and round and circumscribed. They don't look like they're invading the other tissue. You can see the borders of them nicely, as you can see in figure 1. Stellate lesions are generally nasty lesions. On this one in image 2, you can't see the borders so well, and it does look like it's extending out into the surrounding tissue. So think of stellate as having the rays of the sun arms or octopus legs. It's invading the surrounding tissue. Then number 3 are just areas where you go, oh, that there, should it be there? A lot of these are going to end up being lymph nodes. Sometimes they're nasty things, but they just don't fit any of our patterns that we're looking at. Now, generally the breasts, when we look at them, the right breast, and we compare it to the left breast, they should roughly look the same, so that we should have symmetry between our breasts. And if we look at the amount of glandular and fat tissue, it should roughly be the same. So if they're different between the right and the left breast, so we've got one breast bigger than the other, then we've got distortion, and we're going to start worrying about why that's actually happening. So on image 4, we can just see that most of the breast here is fatty, and so it is on the other side as well. However, we've got this denser area just here, and so we'd be suspicious of that denser area because it's not there on the other side. Now, microcalcifications are just tiny little calcifications, and that's the whole point of doing the screening mammography, is to pick up cancers when they're at this microcalcification level, before they've spread, when they're tiny. So that's really what mammography is all about. We want to catch it while it's at this microcalcification level. Not all microcalcifications are nasties. Some are all right. It's all about the shape of them. So it's about looking at those calcifications and the shape, which again, we're going to need our coned magnification views and possibly then still magnifying glasses. So let's look at our circumscribed lesions. So these are the ones, they're usually generally round. You can see the borders nicely. They don't look like they're affecting or invading the surrounding tissue. In the majority of cases, they're going to be benign lesions. So they're going to be things like cysts, your lymph nodes, your fibroadenomas, all of which are benign lesions. And remember, with these, often what we'll do is we'll do an ultrasound as well to look at what they look like on ultrasound, and then we might follow them up in 6 to 12 months just to make sure that they haven't changed in size. Now, malignant ones, on the other hand, they invade out into the surrounding tissues. Often you won't be able to define the borders quite so well, and they won't be quite as round. So they can have lots of lumps and bumps, and as we talked about earlier, those octopusy sun ray legs coming out from them, which just shows that they're distorting and invading into the surrounding tissue. And remember, it's those microcalcifications we're looking for. So here's an example of some benign lesions, and with breast cysts, the classic appearance is it's well circumscribed, and so you can see around the border of it, but it also has a radiolucent halo around it. You can sort of make out like we've drawn a dark line around the outside. Now that is a classic appearance for a breast cyst. We can see that here and here as well. Now see these dark lines just here? That's what a fold in the skin of the breast will look like. So that's a breast skin fold just there. That's what that will look like. So they're all benign breast cysts. Fibroadenomas, again, are benign. They will often look like cysts, however sometimes they can be lobulated, which makes us worry about them. But you'll notice on these that we haven't got that halo effect around them, so we're going to be a bit more suspicious and think, oh, these are not cysts. However, they look like they should be cysts, and they often turn out to be fibroadenomas. The other thing that can happen if fibroadenomas are there for a long period of time is they can calcify. So if we look at this one here, we've got lots of calcification. So this isn't microcalcification, it's lots of calcification within the lesion, and they refer to this as having popcorn in the breast. And if you've got popcorn in the breast, you're likely to be a fibroadenoma. So it's just calcification within the fibroadenoma. The arrow up is really quite large. It does have a little bit of a halo effect happening around it, but this one actually turned out to be an abscess, which is just an infected cyst. So drain that off and the patient will feel much more comfortable. This one turned out to be a lymph node within the breast tissue, which can happen. And this one here is actually out on the skin, and it's a mole. And when we do mammograms, we often mark on our sheets any skin markings, scars, moles, anything like that on the skin, so the radiologist is aware of them, because they can show up in the images. Now, they can also be nasty, so these are all nasty ones. So again, magnifying them up would help us look at them, but if we look here, it does look round. We can see the borders, but it does look like it's got a little octopus arm coming out here. So they're malignant. And this one, again, not quite as well circumscribed, a little bit lobulated and maybe starting to invade the tissue. So again, that was a malignant one. Now this is an interesting one. The image on your left, this was the mammogram in 2009, and you can see that we've basically got fatty breasts, just all fatty, except for this one tiny little area just here, which wasn't picked up at the time as being anything nasty. The lady came back in 2011, and look at what that little area has now become. A huge, big, lobulated, really lobulated mass, still within mostly fatty breast, but you can see the change in the breast within that 2 years. So that's quite a nasty cancer, and you can see it is vading back into the chest wall because there's the pec muscle coming down. So that's actually quite a nasty cancer. Now these are the stellate lesions. The picture here is like a fireworks. As I said, octopus arms, rays of the sun. It's the tumour growing out into the surrounding tissue, and the majority of these are going to be nasty malignant tumours if they've got this appearance to them. So here's an example of quite a few with some stories attached, but on all of them, if you look at all of them, you can see we've got a mass, and then we've got those stellate arms projecting out into the tissue and actually affecting the tissue. And this is often when we can see retraction of the skin or even the nipple, depending on where these lesions are, because it's those arms coming out, the stellate part coming out, that can be pulling at the tissue around it. So if we look at these lesions here, these actually have a retraction of the nipple, and it would be a new retraction. Here's the nipple just here, and we can see then next to it there's an indent that wouldn't have always been there. And what's causing that is this lesion back here. So this is the cancer, and it's having a pulling effect and pulling the surface of the skin in. This one's a really quite large a stellate lesion, and this is the nipple here, so it should be projecting out. It's actually been pulled right back. It's latched itself, the tumour's latched itself onto it and pulled it right back in, so it's completely retroverted nipple just here, and this is the tumour pulling that nipple backwards. And then we get all our weird and wonderful non-specific densities that we're not sure of. We'll maybe go to ultrasound, they'll do potential biopsies on them. So this is just some examples. So this was a sebaceous cyst, nothing to worry about just here. Looks nice and round and circumscribed, but we want to know what's going on. And here, at first look here, it looks a little bit like a lymph node just sitting up in the area here. They've managed to compress it down, but what this one actually turned out to be was a cancer. So you can see how difficult it can be to diagnose these things and how easy it is to assume that it's something else. So here's asymmetry of the breast. Now, not every asymmetry of the breast from one side to the other is a nasty. It's just ring a bell for us that we need to look a bit harder and closer, and is there something nasty going on? And sometimes it's just the person. It can be from their genetics. They've been like it all their life. Sometimes it's sort of small and focal and only covering a small area, and sometimes it's diffuse and covering large areas. So these two images are actually both genetic asymmetry. They're nothing to worry about, but we can see our dense glandular tissue and our fatty tissue, and maybe a little bit of dense glandular tissue in here, but on the other side, a lot of dense glandular tissue at the back and here, and then the fatty tissue. So asymmetry between the breasts, but it's nothing to worry about. This breast here is very fatty, maybe a little bit of glandular tissue up here, but very fatty. Compare it to the other one, we've still got quite a lot of glandular tissue on the other side. So again, nothing to worry about, just normal for these particular patients. However, if we look at this patient, now these are the craniochordal view and the mediolateral oblique view on the same patient. When we look at the mediolateral oblique view, there doesn't look to be anything overly noticeable, and you maybe come into this area just here. But when we go to the craniochordal view, we can see that in comparison to the other side, we do have this marked density happening just here. And you go, it's not on the other side, it's different to the rest of the breast tissue, so it's worth further investigating what this is. And it may be nasty, or it may not be. And this one was a cancer. And here's our microcalcifications. So this is the reason that we talked about in preparation, that we don't want any of that aluminium from powders or deodorants or perfumes, because it can mimic these little tiny microcalcifications. And they're what we're looking at, and the pattern of them, to determine whether we're picking up a cancer, and hopefully picking it up lovely and early with these microcalcifications. So, calcifications within the breast are common. Remember, they're not all going to be the malignant, however, a good proportion of them will be. And what we're looking at is whether they're in the duct. So, mammography is actually not great or no good for looking at cancers within the lobules. We're mostly picking up cancers within the ducts, and they make up the majority of cancers that occur within the breast. So if we look at the duct calcifications, they'll follow the shape of the duct, and they'll often be branching within the duct, so growing within the duct itself, where the lobular ones will look circular and a bit like a flower with its petals around the outside. So you can sort of tell whether the calcifications are within the lobes or the ducts of the breast. So these are what all the benign ones actually look like, and I'm not going to go through all of them, but you can have a little look at this slide. So these are benign looking calcifications. Once we do our cone magnification views, if the calcifications look any of these shapes, we're not worried about them. And the thing about most of them, when you look at them, they're very uniform. We can see the borders of them nicely. They're nice, even sort of shapes. And so the list here has what it looks like, and then therefore what it will actually be. And let's have a look at some. So on this first image here, this is actually looks like it could be calcification with a duct, but it's calcification within a vessel. So that's benign and nothing to worry about. And these are the rods. You get multiples of them, and they're related to mastitis. So if we get lots of these sort of short little things, They're referred to as rods, and again both of those are benign. Then we can get some round looking ones. This first one here is our fibroadenoma calcified, which is our popcorn appearance. This one here is fat necrosis, where the fat has started to die and be resorbed, and these are often referred to as pearls because they look like a pearl from a pearl necklace, and they're just cysts, they're nothing to worry about. That's what pearls look like. So they're all benign types of calcifications. If we now go to malignant ones, they won't be uniform, so they won't all look the same. Often their borders will be irregular rather than nice and smooth, and again, if they look like they're growing along the duct and have this duct and branching pattern to them, then we're going to assume that they're malignant. So on this image here, we've got a cluster of, they usually refer to them as clusters, cluster of calcifications in the breast, just in this area here, and then they've done magnification, magnified just that area up, and now we can see the detail of all of those calcifications now in that area. So we can see that they're all different shapes and sizes and really irregular, and make out maybe that they're growing along the duct. So this was malignancy, and it was ductal cancer, ductal carcinoma in situ, which is referred to as DCIS, ductal carcinoma in situ. Here's some more. So here we have a mass. We've got calcifications spread around multiple parts of the breast, and when they have magnified up some of that, again you can see the calcifications and the branching of it within the ducts themselves. So again, this is DCIS, or ductal carcinoma in situ, malignant. So this is just a brief summary of the carcinomas, the main ones that affect the breast. As I stated earlier, lobular cancers aren't picked up on mammograms. We're picking up on mammography the ductal carcinomas, and as you can see, the greatest proportion of cancers that affect the breast are the ductal carcinomas. So we don't pick up every type of carcinoma of the breast, just the ductal ones, and they can be within the duct, or they can be invasive and infiltrating and spreading out into the breast and invading, and therefore nastier. So you see we're picking up the most that we possibly can. So if we look at whether it's referred to in situ or invasive, just looking at these diagrams, we look at the cancer and the wall. It's still contained within the wall if it's in situ. So in situ means it's still within the duct. It hasn't grown outside the duct wall. It's still contained within the duct. Much better prognosis. That's what we want. Once we hit invasive stage, that's grown out through the wall and invading out into the surrounding tissues. And these are the ones that spread to the lymph nodes much quicker and are nastier, and the prognosis for our patients aren't as good. If we had to have anything, we'd want our in situ, not our invasive one. Now, just to finish off this summary of mammography, at this stage, and goodness knows what the future is going to hold, even though it has the negative of using a low dose radiation, which is absorbed by the breast tissue, and the breasts are radiosensitive organs, mammography is the gold standard for imaging of the breasts, and that may change in the future, but at this stage it really does still stand that way. And remember, with the screening program, we're doing asymptomatic women, and we're looking to pick up the cancers when they're at that microcalcification level before they form masses or indentations on the breasts or something like that. So it is used for screening, and we are irradiating the general population who don't have symptoms, and giving them this dose of radiation. but it's all about picking up cancers earlier. The earlier we can pick up the cancers, the less likely they are to spread, and the better the prognosis and the life expectancy for the patient. Now, while there's lots of other modalities we can go to, such as MRIs and ultrasounds, we can also do biopsies, put hook wires in and things like that for surgery under mammography. Sometimes they'll do them under ultrasound if they can see the lesion in the area they want to go into under ultrasound. However, if they can't, then we'll need to do it under mammography, which means getting the patient into the room. And here's the lesion here with the red circle around it, and the specialist will put, the radiologist or the breast specialist will come and put a wire in, and they call it a hook wire because it has a hook on the end to hook it into place, and the wire will stay on the outside of the skin. Then the patient goes off to surgery. So when the surgeon opens the patient up in theatre, they know that that bottom of the hook is the area where the lesion is, so it allows them to find the lesion. This is just circling it on ultrasound, and then what they often do is in theatre, when they take out the lump and the hook and the wire, you can see it's still attached. They like to take a good margin around the lesion as well, because there could be invasion that we're not seeing that's very fine. So we need what they call nice margins around any tumour. And this will be sent off to pathology for looking at, but we often X-ray. It'll be sent, the patient will still be in theatre, and you'll get the specimen come down and we'll put it on the mammography machine and image it to make sure that they have gotten the lesion all out and to have a rough look at the margins. And then you send the image back and they'll go, oh, okay, I'm happy with my margins here, but I think I'll take a little bit more out, say in this area here. So it's just that double check while your patient's on the table before it all goes to pathology. So all these can be done under mammography. Really handy imaging for early detection of breast cancer, and that is the aim of what we're doing with all of our patients, and particularly the aim of the screening program.